Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Just go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need. Back to the question from Allison. Once a crown is placed, how long do we expect that to last for the patient? And will it eventually need to be replaced? And I'll make this a short answer to a very short question. And the answer is you expect that for the lifetime of the patient if it's done correctly. If we're doing it, and in our track record, we've had one of those come off, maybe two, with a really short crown that doesn't have a lot of crown surface that we were trying to preserve. But after thousands upon thousands of crowns that we've placed over the last 20 years plus, they just don't come off. We use a cement that is very tenacious, and that was actually longer than I expected to answer, but they don't come off. So Kathleen, what's the success rate for vital pulp? Kathleen, I answered that already, but we do have a couple of studies that show more specifically. This was done, study was done back in 2001, and the percentages for these were all done 36-month post-op, 88%, 40%, and 23% at 48 hours, 1 week, and 3 weeks. So you can see with a week, you drop down from over 90% within 48 hours, and then it goes exponentially bad from there. So we don't recommend that at all. We're gonna recommend extraction or root canal and not vital pulp therapy. And then more recently, Dr. Verstrata and his colleagues, Dr. Verstrata's at UC Davis, and done a lot of research over there on a lot of things veterinary medicine, more recent prospective look at cases, and looks like in their success rate was 92% for the cases that were controlled. And I haven't recently read back in this study, but that's using MTA and probably within that 48-hour window. So great question there. Thanks for that, Kathleen. Can we provide general guidelines for when to refer to a specialist for root canal, the time frame, the characteristics, the radiographs? And we've touched on this a little bit, Katie. This question comes from Katie Holly, and we've touched on that a little bit, but let's look more specifically about time frame. So time frame we've talked about doesn't matter for the most part, unless we're doing vital pulp less than 48 hours. The characteristics of the fracture, if there's pulp exposure, we definitely want to refer if there's radiographic evidence of increased pulp diameter compared to adjacent teeth or the same tooth on the same jaw on the other side, then that is an indication. If that tooth that's fractured has a larger pulp chamber diameter, that means the dentins stop growing and the pulp cavities stop getting smaller with dentin growth. That means the tooth is dead, and so that would be an indication radiographically. And then also the other indication would be if there's a periapical lucency. So that's when you have an option to refer for root canals. Nice question, Holly. Katie. Melinda, what classes are available to learn root canals? Short answer to that, there are none. The AVDC prohibits veterinary dentists from teaching root canal therapy to general practitioners. The learning curve is way, way too high. And I used to tell people 10 years ago, 12 years ago, whatever it may be, 15 years ago, that I've been doing root canals after becoming a specialist for 10 years, and I think I'm just now getting good. And so that kind of puts perspective into how difficult these things are from a decision-making standpoint. So we don't teach these. They used to at the dental forum, they don't anymore because they realize that's not the thing to do. You don't see enough, you don't have enough practice. And enough practice is probably 5,000 to 10,000 hours of practice to get really good at these where you can do them and do them quickly and efficiently. So not something that you'll do in practice, not something that you're willing, unless you're specializing, to put the time into to make it happen so that you're good and you're providing a good value to the patient. Anisha, how do you convince or explain to clients the need or importance of extracting devitalized teeth, or ones that are just partially extracted and the owner perceives the dog not to be in pain and they are acting normally? So that's a great question, and that comes up a lot in our courses. So client education, this is one really good example that takes all those things that you talked about and puts it into one good example. You've got a tooth that may be slightly discolored. There's no crown impingement. There's no changes in that tooth that are visible other than the color change. Or you have a tooth that has a lucency radiographically but looks perfectly normal with no color change. So those two situations may be difficult to explain to the client without having good images. So if you've got the Veterinary Dental Image Library, which a lot of you have, I think when you registered for this workshop you had an opportunity to get that. I think it's $17 or something like that to get it. It's got a lot of images that you can use for client education. Or search for Veterinary Dentistry Image Library in my name. You'll be able to find that. You can get that as a PDF. You can put that on your computer and use that for all client education. You can show them a lucency on a tooth and let them know that that tooth was what happens when these teeth that are discolored are allowed to go for any length of time. If you don't have that patient where you've got the radiograph of the tooth that's not discolored already. So that would be for a discolored tooth in the exam room. Show them what that progresses to in most instances, even if there's no pulp exposure. That discolored tooth is discolored because the pulp is dead or dying. When that pulp dies, it releases toxins and metabolites that destroy the bone around the tooth apex that result in that lucency. So it doesn't have to have infection associated with it. It's just those toxic metabolites of pulp necrosis that cause the inflammatory condition that results in the periapical loss of the bone. So if that's the case, then you're gonna not have a radiograph if you're talking about this in an exam room. So that's where images that have been taken previously come in handy. If you've got the radiograph and the client has declined extraction or root canal because they don't believe it's a problem, then you show it to them at discharge and let them know this is a hole in the bone that's created because the pulp's dead. That hole is not going to stay stable. It's going to get worse. It may cause a fistula eventually, although it takes years for that to develop. And in the meantime, that patient is suffering silently because that is uncomfortable, if not painful, with that bone destruction and inflammation that's going on. So hopefully that answers your question. Certainly it covers that whole scope, I hope. And then Christiane, what can I advise my clients who are interested in referral for a potential root canal as what to expect as far as monitoring goes for the lifetime of the animal? That's another real practical question from a potential referral, from a general practice potential referral standpoint, which should come up a lot now that you guys are well versed in what the potential for root canals would be versus not root canals. So what do we tell the client's going to be involved with that? So number one, if you're coming to my practice, we're going to put a crown on that tooth, and then unless that patient's older and doesn't have an expectancy of 5 years to still be with us, we're going to put a crown on that to protect that, because we know that micro leakage happens around any composite restoration and can start, and generally does in humans, around 5 years after that restoration is placed if it's not covered with a crown. And we're going to put a crown on there. That's a 2-visit thing. If your dentist that you're referring to places crowns, which a lot of them do, some of them don't, then that is going to be a 2-visit procedure where we do the root canal, we do the preparation for the crown with burrs, and then we make an impression, send that off to the lab, and then in 2 weeks we get the patient back. So there's going to be that recheck. And then when we get a patient back, or when you get a patient back for a routine cleaning in a year, 18 months, 6 months, whatever it may be, depending on the patient and their periodontal status, we recheck the radiograph. And in our case, we've got pretty much, I would say, 98% of the ones we follow up are going to work. There's very few that we've ever had to extract or do surgical root canals on over the years. Depends on what you look at. 92%, 93% is what the literature suggests. There's a real good possibility there's not going to be any problems or follow-up going forward except for routine radiographs. So that should answer your question. If there is a failure, which happens by some measure, then that's either redo the root canal, a surgical root canal, which is a whole nother ballgame and conversation, or an extraction on your end, or the referring vet, or the referring dentist, or the dentist that you refer to would be doing that. And if that's coming in to most practices, it's down the road a bit, where it's had time to develop over time, and there may be root dissolution in conjunction with that, and so extraction is usually what ends up happening with those. All right. Thanks, Anisha Kumar, for that. Beth Shawn had some questions the last time, and she's got a question this time. If tertiary dentin's present at the site of a fractured crown, no lucency present on radiographs, do you need to extract? The question is, it all depends on the radiographs. If that has been sealed and it actually sealed off with tertiary dentin, but the changes had already happened deeper and the bacteria had gotten in there, or that tooth was compromised from a pulp standpoint and the trauma itself killed the tooth, then there's no reason to extract, and there's probably no reason to really follow that up, because the tertiary dentin has already come in there and healed that, and if there's no radiographic changes after that month or multiple months that it's taken for that to happen, then there's a chance that they won't. Most of the tertiary dentin we find is generalized with wear that's happened in younger patients over time, that the owners have stopped the wear behavior, just as an aside. So if there's no changes that would suggest that's a non-vital tooth, you do not need to extract. You don't want to extract. Let's go down to Megan's question. What is your recommendation for a puppy who comes in with a fractured deciduous tooth? And the answer to that is extraction, and extraction that day, if possible, because that pulp's exposed. That pulp is huge, and it's going to get infected if it's not already. The puppy may or may not show that it's uncomfortable because they're puppies. They're not 90 to nothing all the time. Nothing seems to bother them for the most part. And any things that they do, rubbing their face on the ground or rubbing that side of the face, maybe just be perceived as puppy behavior. They're active anyway, and so it's not really picked up if they're uncomfortable. And those things can abscess, and often do, and they go undetected, and the dog suffers until the body takes care of that and eventually resolves it after weeks. Always extract those, and always get pre-op radiographs to make sure you're getting all the tooth root, because some of those might be partially resorbed, and a lot of them will have apical to the mucogingival junction, or at the mucogingival junction they'll have a fistula. You can actually see that fistula, but not always. That's when it breaks through the bone and affects the tissue. So yes, you want to extract those. I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at iv.org/INV.